You're the watu wa madawa. I call the pharmacist watu wa madawa, not miadarati, the madawa. Now, why are we buying drugs from outside the country? I always ask myself, are our brains so shrunk that we cannot produce? This is a superpower seated here. Even basic normal saline. How do we get to import normal saline? Sure, maji na chumvi. Even my grandmother still asks how we are importing maji na chumvi, maji na sukari, how we are importing it. Didn't you learn this in school? Aren't you learning it? Then why aren't we producing? What is causing you not to be able to produce? If you were producers, you're able to transfer that production to all the other regions in East Africa. So can we start producing? Can we start innovating and ensuring simple things like detergent? Imagine sabuni tunanunua. How about us producing that soap, that jig in our workplaces? We saw people being creative enough to produce sanitizer, but the pandemic left and the brains shrunk and the production stopped. And now we are buying. We are going through the whole procurement process to buy. Be innovative, get out there, do something different, come up together. I always say you don't have to finish school to be innovative. Innovate now, even when you're in school. Start those enterprises, those manufacturing industries. Even now, collaborate. We are here. Old money, as people call it, I don't have that old money. Sio mingi sana, but my money can also be used to invest in your investment. And that's the way people build each other. Think like the Indians. Are they here? Unfortunately, we don't have any, but they usually work together. For the Somalis, they are here, they work together, and they ensure they bring their money together into one pool and produce it. The HIV statistics. I'm a mother of teenagers, and I was brought up by the best mother. I always say that. My mother taught me everything about contraception, about how to use a condom, and when to use it, and when not to use it, and packed me to college with a box of condoms and a package of contraceptives. But every time I would look at those condoms, I would say my mother is seeing. And she could appear tomorrow, mother seeing. Yes. But she taught me all the principles that were required in order not to get pregnant. But at that time, that's when HIV was coming into the country. It's when we were burying in paper bags and not going near anyone with HIV. But I learned a lot, and from the right source. So we have a responsibility as youth to ensure that we advocate for the teaching. I would never have seen a condom, penis dummy, sorry to say it openly, but my mom came with everything. She was a family planning nurse, and she came with everything home. I was going to college to Patrice, School of Clinical Medicine, and Mombasa was the source of the HIV, you remember. But for a number of years since when we were 9 years old, my mom and my uncle used to host conferences like this for me, my cousins, and my siblings, and all of us. And we would be brought together and educated everything from A to Z and given opportunity to ask questions. I have started the same with my nieces, my nephews, my friends' children, and anyone who's willing to join in when we have our annual youth camp. And during the youth camp, we allow the youth to talk, because my mom used to allow us to talk. Talk and say what you want to ask without fear, and get explained what you need to ask. We never ask questions like the ones my teenagers ask. Theirs are way hot ones. But I am learning to be ahead of them and getting to read more and get to understand them. The question of LGBTQI is a big question for the youth. We are pushing them even to that direction because of how we explain to them the whole issue of adolescent pregnancy. And to them now, they run off from this side of the male agenda to probably similar sexual partners. And are we teaching them also how to protect themselves? Because, well, some choices have consequences. They also transmit infections, but are we educating them of the possibilities of getting infected when they engage in LGBTQI? And how do we ensure that that message is passed, and how do we ensure that we also encourage contraceptive use? Sorry for taking all the airtime. Okay.
All right, thank you for addressing those questions. I think tunapenda closing remarks. For questions, huh? Yeah. Oh, all right.
Okay, my question to Dr. Joy, I'll be very brief. I've been following up on the new bills, or which are now acts right now, and I think there's almost a consensus with healthcare professionals that the FI Facility Improvement Act is very good, the digital health one, but I think there's the one for the SHI, there's a lot of debate about it, but I don't know so much about insurance, so I'll just focus on the question I want to ask about primary health care. So like you said, someone like Charity Kadambi, this thing of CHPs or CHVs, however they are referred to, it's nothing new. So it has been tried before. I've heard that it has been there since even the days of when Kibaki was in power and all that. But right now it seems like, and I know for things to work, there needs to be a lot of government goodwill. So my question is, previously, when they tried the issue of CHPs or primary health care, what were the stumbling blocks? Why didn't it work? And in your capacity, now that I know you're also part of, how do you call it, KTRAC? So what's the different thing that is there that's going to make it take off and hopefully work this time, as opposed to the other probably multiple times it was tried and it didn't necessarily work?
Thank you very much for that question. In terms of
almost the same, I just wanted to ask at the same time, because my name is Naila, and I have a public health background. So I'm interested because you're talking about the community health strategy and primary health care services and the CHVs. So you're telling people to leave their air-conditioned offices and go to the community level. But previously, the compensation for engaging in that has been quite low. And that's why people are really discouraged from doing that. And at the moment, the government said that they're going to increase the community health promoters, I guess, to about 100,000 to go into those places, to the communities and build homes. I mean, do you think that is sustainable? I mean, because there was a problem before with compensation, now they're trying to increase. Maybe you can talk about the compensation, the sustainability of that. Thank you.
So I answer those two. Well, for the social health insurance, one thing we've had benefits because we are going to pay for that one who can't be able to pay. And I'm okay with that. I've done my math. I've looked at the many WhatsApp groups per year that I have to contribute for in terms of either healthcare, death, or issues that need addressing at the social health level. And for me, I'm spending almost 30 to 50K per year. Not for my relatives, but for anyone and everyone. So if you add me, there are times I say, hata ongeza ifike 5,000, hakuna shida, we are fine. Let me pay that per month, but not have to pay it in so many WhatsApp groups. But ensure that that primary healthcare facility is functional, so that I don't end up having to also cater for their fare to come to town. And think about it, you've done that also. Now for the community health promoters, it's a long journey, and they've been there, but they've not been remunerated. They've been working from their hearts and working to ensure that they bring people to link them with healthcare services. Initially, we had agricultural extension workers. We had community health workers who sincerely, they used to cane us as children. If you don't have your compound swept, you don't have water, you don't have grass cut. Those were things that they used to do in the community, and they would come along with the chief. And that was being done, and it was efficient. Malaria was a big issue, and it wasn't basically a regional issue. There was also highland malaria. Ticks, fleas, jiggers were issues, but community health workers were helping a lot with that. Now come to the issue of how do you come into the community? There are many ways. And as we said, yes, Karambi started out as a community health promoter, but she felt the need of now coming in to do policy and change the way people do. She's a very educated woman. By the way, she was my school mother in high school. I came in Form 1, she was in Form 2. That was my school mom. And it was nice to meet her again in Nakuru. And we've had she's very down to earth, but she's also a learned person like all of us. She's a professional, but she dirtied her hands to become a CHP, but to grow within that community and assist them and see their problems. And because she's an educator, she's a teacher, she decided she needed to improve the education system of the community. If you go to Njoro, no child stays at home. They're in school. They have a meal, they have buses, they ensure that everyone gets to school on a school day. Because she saw a gap. How about you as a pharmacist? What's the difference? If you take the CHP work and go out there and see a gap that you can fill out as a pharmacist and be able to assist, would it be harmful? You're being paid 5,000 shillings. That's one aspect. Number two, maybe you're a community pharmacist. You're running a community pharmacy. But for people to come to you, you need to go out to them. Take some community outreach project out to the community, work with them, bring them back to the pharmacy, tell them this is the pharmacy. And this is where you can get your medicine, but once in a while I'll come to the community and take your blood pressures. How about at the household? Community pharmacists have a lot of role, ensuring that that drug therapy is adhered to. Are you checking on their drug therapy regimens? Are you checking on any adverse events? How do you monetize that? The social health insurance gives you an opportunity to also charge that service that you go to the household or that you go to the community. But it is you who will need to be innovative enough. So I hope I answered that question adequately.
There are no more questions, but I would like for the other two panelists to give us a parting shot because a lot has been said and you have been very comprehensive about it. So maybe you can give us a parting shot, each of you, in 2 or 3 lines, 2 minutes.
All right, thank you. Thank you, Dr. And my parting shot is in line with what Dr. Frank, the speaker that came after Dr. Frank, he gave a quote about doing what you can with what you have, where you are. I know many of us as young professionals, we have our ambition really set high, and to some extent, I always say that internship spoils us. You earn in 6 digits, but when you come out here, you find that what is being offered in the market is way below that. That does not mean that your skill has lost relevance in the society. It's the market forces that you are confronting. And amidst that, find a space where you can put into practice your skills for the betterment of the society and also to settle your bills. Thank you.
Thank you. Again, thank you for your attention and your time. I always get the worst spot just before lunch. It's a thing. It just happens to me. But I just want to say, if it does not last after you, you did not do it. Okay? Whatever it is you want to do you want to strengthen a system? Do you want to make it more resilient? Whatever you want to do, if it does not last after you, you did not do it. Okay? Most importantly, in whatever you do, make sure it is sustainable. If it is helping people, you want it to keep helping people, whether you're there or not. Okay? If it does not last after you, you did not do it. Okay?